Good afternoon and a warm welcome. You're on a webinar entitled An Introduction to the Delivery of Trauma-Informed Care in Medical and Mental Health Settings. This webinar is hosted by the Violence Prevention Initiative at the Children's Hospital of Philadelphia, also known as CHOP. My name is Suzanne Hill, Outreach Director of the Violence Prevention Initiative, a CHOP-wide effort to interrupt the cycle of youth violence. The Violence Prevention Initiative builds on years of hospital and community partnership and research to address bullying, assault, re-injury, and domestic violence, with the hope to become a national model for hospital-led youth violence prevention. The concept of trauma-informed care is at the core of the Violence Prevention Initiative's efforts, and we have heard the need for training on this topic. Our goal for today is to provide an introduction to the impact of trauma on children, families, and providers, to discuss assessment and trauma-informed actions, and understand what types of further training may be helpful to help put these skills into practice. This webinar will be the first in a quarterly series of webinars hosted by the Violence Prevention Initiative. Now, it's my pleasure to introduce today's speaker. Meghan Marsac is a PhD pediatric psychologist and behavioral researcher. She is also the Director of Training for both the Violence Prevention Initiative and CHOP's Center for Injury Research and Prevention. Dr. Marsac leads research to better understand how children and families facing medical events cope with illness and injury and to promote positive recovery. I'll now turn the mic over to Dr. Marsac to begin our presentation.
Thanks, Suzanne. So one of the primary goals of today's webinar is to really stimulate interest in the topic of trauma-informed care and to hopefully provide some underlying basic knowledge that then you can think about with the teams that you work with and determine what kinds of additional training or how to best integrate it into the care of the kids and families that you may be working with. As Suzanne mentioned, today's webinar is sponsored by the CHOP Violence Prevention Initiative, and I also want to mention that the Center for Pediatric Traumatic Stress has supports a number of our efforts in trauma-informed care training and has provided a lot of the research behind today's talk. I have nothing to disclose for today's presentation. So in a review of the learning objectives for today, we're going to spend some time talking about the prevalence of trauma exposure. We're going to talk about the impact of trauma on children, family, and providers. We're going to talk about a few assessment and trauma-informed actions as introductions of things that we can start to do with our patients and families. And we're going to start to think about and discuss what types of further training might be helpful to actually develop trauma-informed skills that we can integrate into our practice. So when we talk about trauma-informed care, there's a number of different definitions that have been used throughout the community. And so for today, we have selected the SAMHSA's definition, and that's the Substance Abuse and Mental Health Services Administration, of taking a trauma-informed approach. So this includes realizing the presence of trauma, recognizing how it affects families, children, and staff in full organizations, and then responding in a trauma-informed way in order to reduce the impact that trauma has on patients, families, and systems of care. So when we talk about trauma-informed care, we really take this from a service system approach. So we know that many systems regularly come into contact with trauma-exposed children, and that there's a key role for each professional working in different systems to help prevent trauma and help prevent the long-term impact of trauma that is within their job scope and training. Some examples of professionals that interact with youth on a regular basis that have the opportunity to support youth are those in law enforcement, those working in school systems, those working in child welfare, and today we're really going to focus on those working in mental health and health care. As we go through this presentation today, I want to provide two case examples of children where trauma-informed care really helped address situations that they were having within the medical system. I'd also encourage you to think about your own cases, your own work with families or interaction with families, and think about how this applies in your particular setting. So the first example I want to bring up is a child that was seen in a primary care office. This child came in for a well visit, He's a 13-year-old male, and he had been excelling in school, getting straight A's, doing really, really well. And when he presented to this appointment, it came to the physician's attention that he had a severe drop in his grades. And the physician was astute enough to recognize that that was something that was odd for this particular teenager, but didn't know what had happened. So we'll talk more about the explanation about what happened with that student as we walk through. But the physician was thinking about what happened, not what's wrong with the child, but what has happened to this child that has created this situation. A second example that I'd like you to think about is involving a child age 7 in oncology, getting treated for cancer. And in this situation, the child was fairly challenging with some behaviors outside and in the school system, and then was presenting for treatment. And one of the things that was happening with the with his medical treatment was that she was unable to sit still and be able to have the port accessed as she needed it, as required for her treatment. So in the medical team's perspective, they had seen this behavior as oppositional, and we were consulted to see if there was something that was going on with this patient. So please keep those two case examples in mind as we move forward. So this brings us to the first part of the definition of our trauma-informed care approach, which is realizing the prevalence of trauma. So we're going to spend some time talking about children and parents' exposure to trauma in the systems that we work in, identifying potential new trauma or re-traumatization with these experiences, and then helping identify staff reactions to trauma exposure as well. So when we think about trauma exposure in youth and in families, we can categorize it into several different subsets. So we have the children that experience high impact, high profile events. And these are the events that affect large number of children and families all at once. So these are things like the disasters, mass violence, terrorism, some of the school shootings or hurricanes. Those are the types of events that they get a lot of attention from the public. It affects a large number of children and families all at one time, and there's often a lot of resources associated with these events. Then we have the children and families that are exposed to lower profile everyday events. And these are the events that added up end up affecting millions and millions of families each year, but they're affecting children and families one at a time and out of the public eye. They're very frequently occurring, and many children are affected. These include things like sudden acute illnesses where the child ends up in the hospital, things like a house fire, a traffic crash, potentially witnessing violence or experiencing violence, or having some kind of injury. The third group that we can think about for trauma exposure in these kiddos is those children that are experiencing chronic stress. And in some of the literature and some of the groups, they talk about this stress as toxic stress, particularly when we're talking about poverty. So these include events like violence. So often violence does not occur as an isolated incident, but can often be a community experience. It can include domestic violence, which again is often repeated within families. It's not usually a one-time experience. Bullying, which is also repeated quite often. And then potentially poverty, which brings upon a number of different traumas with kids having to figure out, where their next meal is coming from, and families exposed to a lot of different traumas in the communities often. And then finally, this could include things like ongoing medical conditions and care, which have the potential to be traumatic for families. The next aspect that we need to consider is realizing the potential for new trauma or re-traumatization. So if you're working in a medical setting, re-traumatization can occur when a child comes in already, they have an abuse history that you may or may not be aware of, and then something happens in that setting that is a new trauma. So for example, sometimes we see this in the case of sexual abuse with kids who have had sexual abuse in the past, and they come in the hospital and you need to do exams on these children. And the exam itself could be re-traumatizing for that child given their past experiences. In the mental health setting, we could see this even having an assessment where a child is in a room by themselves with a mental health provider. If they have a trauma history, that experience in and of itself can be challenging. New traumas that can occur, I think, are pretty evident by the pictures that we have in front of us here. You know, if you think about the things that kids are coming in and facing in the medical setting, you know, sometimes things that seem as simple as shots or procedures are things that are new experiences for this child or family, even if as the medical team, these are things that you're doing on a daily basis. These are things that could be potentially traumatic for the child and family. And I ask that we remember as a medical team that even if these are procedures that don't seem stressful, that there are things you're doing every day, that you really think about it from the family's perspective and what it could mean to that family. Something as simple as an MRI could be a really traumatic experience for a family if they don't understand what's going on, or if they have anxiety around the reason for the MRI. So this really brings us to talking about, so how many kids and families does this affect? So we talked about the potential for re-traumatization and potential trauma histories in our families coming in. And so several studies kind of give us some insight about the number of families that are affected by medical traumatic stress. And we know anywhere from 5 to 20% of injured and ill children are affected by having long-term traumatic stress symptoms. And we know those numbers are even higher for kids that have had violent injuries that have presented to the ED. Somewhere between 15 and 25% have long-term effects of post-traumatic stress symptoms following their experience of their medical treatment. So in understanding the prevalence and how often that this happens, it's also really important to understand that trauma symptoms affect health outcomes. And there's been a number of studies that have showed the effect of trauma symptoms on functional outcomes, including, as you can see from this slide here, increased risk for endocrine problems, musculoskeletal conditions, greater health problems overall. There's also been some research done suggesting adherence is affected by post-traumatic stress and functional outcomes. So we know that kids that have post-traumatic stress symptoms, regardless of what the actual event was, they have poorer quality of life and they end up missing more school, affecting more functional outcomes for these kiddos. So the impact beyond just the distress of the trauma symptoms themselves, the impact that the trauma symptoms have on the families is substantial and extends beyond just psychological. So realizing the impact of the event, we know that traumatic events and how they impact children and families are influenced by a number of things. And we always like to look at the child in here as being in the middle of all these external influences. So we have a number of circles around the child, for example, family, friends, school, our community, cultural things. And the systems around the child can either act as a buffer and significantly help the child recover from potentially traumatic events, or create a problem for the child or potentially worsen their symptoms. So when we're working in a medical community and we're talking about a medical event, the medical team or health system, and this includes mental health care, becomes a part of that circle. And so the circle around our family and our child has the potential to help buffer the impact of these symptoms on our kids and families. So when we think about, okay, so that is what the impact could be, then we can think about what is the trajectory or what is the typical way in which these families might experience trauma. And so what we often see is we have an event, and this could be a medical hospitalization, this could be a violent event in the community, and then it's very natural for children and parents alike to increase in their level of the symptoms and distress. It's a stressful situation. That's a normal situation. You expect distress. Then for a while, they're, appropriately distressed. And then what we want to see is our children and families return back down and go back to a more normative level of functioning. But for some of our families, that's not the case, and they continue in this distress point. And then when they have this ongoing distress, those are families that we really need to be carefully watching and figuring out how can we support them and help them return to a more normative level of distress. And then we have other families in which the level of distress even increases more and more. And that can be due to a number of different reasons. But those families are of particular concern. And then the other thing that I think is really important to think about when we're looking at the trauma response in our trajectories and what we expect from families is that for some families, it's not just that single event. It's an event and then another event and then another event. You know, and these ongoing events make it really hard for the family to come back down to some kind of normal level of distress. So they're in these situations with this chronic or potentially toxic stress experience. So with that in mind, one of the things that I think can be most helpful when we're working with children and families in these kinds of situations is to recognize our emotional reactions to traumatic events. So we need to be able to understand what do those reactions look like. And so in kids, we have a whole list of different things that we can look at. We know that for kids and families alike, internalizing just some symptoms such as depression can be reactions to traumatic events. We know that externalizing symptoms like acting out or being hostile or being aggressive, those are things that we particularly see in kids. The externalizing symptoms, those are the kids that more often come to the attention of medical teams or come to the attention of medical health providers. These are the kids that are getting in trouble in school or that are difficult problems for the medical teams because they're having trouble getting them to take their medication or they're acting out in different ways. The kids with the internalizing problems or are more withdrawn into themselves, they're quieter, shyer, these are the kids that we often miss because they're not creating any problem for anyone, and so their distress is like a silent suffering at times. And then if we think about specific traumatic stress reactions, these include a number of different reactions, but can be categorized as re-experiencing, avoidance, arousal, and changes in mood. And so with re-experiencing, what we often see in kids is things like dreams. And for kids with trauma, the dreams might not be about the trauma. They might simply be distressing dreams. We sometimes see this in play. We also see avoidance symptoms in kids. If they were in a car accident, they might not want to get back in the car. If they went to see a mental health provider shortly after their event, that mental health provider could be someone they want to avoid because it's reminding them of the event. For arousal symptoms, the most classic example of this is where a car backfires and someone drops to the ground because it reminds them of a gunshot. Other things that often happen are you might close the door and the child jumps, or you have different things where the child just seems on edge and is easily set off because they're in this hyper-aroused state. And then we see changes in mood as well in kids and families. And so just taking a minute here, if you think about patients or parents that you've interacted with or even colleagues that you've interacted with, if you think about parents that have been really withdrawn or parents that are externalized or acting out, sometimes our parents that are yelling at medical teams, yelling at the staff, maybe you need to get security involved because they're making threats. Thinking about this as potential result from potential trauma symptoms or trauma experiences of that family can be helpful. It can be a helpful way to think about it. Another way to think about this is if you think about arousal symptoms and the way post-traumatic stress develops is that you have this fight or flight response. And so with the arousal symptoms, what that means is you're preparing to deal with a trauma. And so your body gets prepared and you're in this hyper-aroused state and you're ready to run away or fight or do what you need to do to make it through the situation. And in the kids and families where this doesn't come back down, you're walking around in a hyper-aroused state. The reactions that you're going to have following that are going to be a little bit different, and your interactions with medical teams and mental health providers are going to be different than if you were able to come back down to your more normalized state. So I think that's also a helpful way sometimes to frame our traumatic stress symptoms. And then again, as we talked about before, ways that we can look for impairment that might be related to trauma, school success, quality of life, and relationships. an impairment. So just taking a minute to think about what these experiences must be like from a child and parent perspective, there's a couple of quotes from some of our families here that gives you really the idea of what was going through their mind at the time. And so from a child's perspective, I thought I was going to die. I was really afraid. My mom wasn't there. So these are the different aspects of that immediate trauma experience that was challenging. Feeling like things will never be the same again. The parents witnessing some of the things that have happened in some kind of accident. So I think it really gives us an outlook as to the kinds of things that our parents and kids are thinking when they're going through these events. So when we're thinking about how can we recognize and what to look for in our patients and families, there's a few other key things that it's helpful to keep in mind. We know that post-traumatic stress symptoms and reactions to trauma are not related to the severity of the injury, the illness, or the injury. There's no common sense indicator for this. Instead, what's the most important is our subjective experience. That's what predicts how kids are going to be doing when they're recovering, and families as well. So if you have a family where you think, oh gosh, that was a really bad prognosis, or that was a really bad trauma, that family must need extra help, versus a family where you think, oh, they seem pretty okay, like they'll definitely recover from this. That kind of common sense thinking actually doesn't work when we're thinking about emotional recovery of post-traumatic stress, emotional recovery from these injuries and illnesses. So I think if you think back about some families that you've worked with personally, you might be able to think about things where this is true for you. And I'll revisit the cases that I talked about earlier. The one case of the child that was in treatment for cancer and was having difficulty with needle sticks. With working with that child and family, what we learned was that the child was not, in fact, being oppositional about the needle sticks and wasn't trying to be difficult for the families, but in fact had developed a traumatic reaction to needle sticks as part of the cancer treatment. And the medical team was strong enough to recognize that there was some kind of problem and did a consultation to psychology at that point. And we were able to work with this family, and by the end of the treatment, the child was able to climb up on the exam table by herself, put out, her arm and get the needle sticks with no intervention. And basically what it took is working with them around their perception about this experience and setting some things up to support this child. And what that allowed for was compliance with treatment, which will result in better health outcomes for this child and family. It also resulted in a lot less stress for the medical team because no one wants to have to restrain kids to give them treatment if not absolutely necessary. I also want to take a minute to revisit the other case that we started talking about. And if you think about the different symptoms and recognizing things, the provider that we were working with at the time recognized that that was an odd situation for that child to suddenly have his grades significantly dropped. And within a 5-minute conversation, we were able to determine that that child had a miscommunication about some of the rules at the school involving whether or not it was okay to wear a hat, ended up getting a detention, was afraid to serve the detention because one of his peers had been shot leaving school earlier a couple of weeks previously because of leaving after detention and not right after school, which resulted in a suspension then for this child. And then because of the suspension, the grades had dropped, and he wasn't able to figure out how to get them back up. And so because the provider recognized this and didn't just say, oh, this kid's just, being lazy or isn't really trying anymore or something's changed, the provider asked what happened to this child. And we were able to work together and involve social work and then touch base with the school to try to get this child back on track. So I think that's a case in which the medical teams in both of those situations were able to recognize that there was something going on for this patient and put supports in place that really changed the trajectory of care and functional outcomes for their patients. So I'd like to offer those as some uplifting stories at this point, as we are talking about the difficulties around trauma in our families. So that brings us to the next part of this presentation about when we're talking about recognizing our trauma reactions. And I think one thing that we've really learned about from talking to a number of medical teams here at CHOP and elsewhere is that, these are very high stress positions sometimes, and we're working with sometimes families that are in very stressful situations on a daily basis. And it's really important for us to be aware of what are our own reactions to these events. And Paul Robbins here at CHOP led a study and collected data from medical providers that were working with kids with significant chronic illnesses, and found that 39% of the staff were at high risk for compassion fatigue, and 21% were at moderate risk for burnout. And I think we talk about compassion fatigue and burnout regularly in medical settings, and I think mental health care as well. And what that means is they're a high risk for the exact same symptoms that we mentioned above, the post-traumatic stress symptoms, including internalizing symptoms, depression symptoms, symptoms of post-traumatic stress, including, re-experiencing, arousal, avoidance, the things that you're taking home with you after work to get the experience out of your head, having difficulty sleeping. So it's really important for us to be able to be aware of our own reactions, both for our own sake to make sure that as providers we're strong and able to continue providing good care, but also in thinking about it in the way it could potentially affect our care if we're having these kinds of reactions and responses. So I think keeping that in mind and thinking about on your medical teams or on your mental health teams, are there ways to support each other, and what are those ways? So that brings us really to starting to talk about how can we respond. So when we're thinking about responding, we're thinking about how can we make assessments and recognize these emotional reactions to these potentially traumatic events, and how can we react in the moment and take a trauma-informed approach. And in talking about responding, I want to really emphasize here, we're talking about responding to every single patient interaction that we're having in every single family. This type of care is not only for families that are considered high risk or that there's a confirmed trauma for. This is a way to support our families across every kind of situation. And so when we think about that, one of the reasons is we know some of the things that happen in a hospital environment can be traumatic for families, but also we don't necessarily know what everyone's past trauma experiences are. So when we talk about conducting assessments, also the one thing that I think is really important to keep in mind, we are not suggesting that we're conducting thorough trauma history assessments with every patient. In some cases, it's not necessary. In some cases, it's not appropriate. And some of those questions need to be asked by people who are trained to ask them. So, it's not necessarily about understanding everything that's happened in the patient's life, but responding in an appropriate way, assuming there have been challenges across many of our children's and families' lives. So I think after we talk about all the challenges of trauma and how high prevalence and how many children this affects, it's a really nice shift to start thinking about what are our opportunities? How can we support these kids and families? And in a healthcare setting and also in mental health care settings, we often see kids right after certain types of trauma. And when we're talking about healthcare, sometimes we're seeing kids right after scary medical events and right after disaster or violent events. In healthcare settings, we are able to reach children and parents who would not otherwise seek mental health services. And this is particularly important for our children and families who are working or who are representing our underserved populations for mental health. So this is really an opportunity for us to reach more people and support more children and families. So we know that with the basic knowledge of medical traumatic stress, which is what we've been talking about throughout this presentation, and also including in that the potential trauma histories that kids are coming in with and the potential violence exposure that kids are coming in with, health providers can really minimize the traumatic aspects of medical care. We want to minimize the child's experience in illness of their injury. We want to minimize the impact that treatment and procedures have on our kids and families. And we want to work on making sure our provider interactions with children and families are as best as they possibly can be. This also allows us an opportunity to screen for high distress and high risk, figure out which of our families do need more help, figure out who do we need to get more consultation for. It also allows us to identify in families what are the adaptive things that these families are doing, and how can we support that just to strengthen what's already going on for families, and to provide basic information and an anticipatory guidance for our children and families. So I'm going to go through a number of resources now in some of the time that we have left, and talk through them a bit and think about, when you're thinking about your children and families, think about if these things could potentially apply to some of the families that you're working with. I think for healthcare providers, one of the best resources that has been developed is this concept of following your DEF. After you have your ABCs done, so the patient's stabilized, they're no longer in high risk for physical problems, thinking about the next step. So don't forget about your distress. This includes managing pain, asking about fears and worries, thinking about grief and loss, thinking about our ease, our emotional support. What does the patient need now? Who else can we bring in for the patient and possibly the family at this point? What are the barriers to the existing supports in the patient's life? And then the F, including the family. So how are the parents and siblings doing? What are the stressors that family is experiencing, and what resources does that family need? Is there any other needs that we could potentially help that family address while they're in our care? And these materials, and I'm going to go through a couple more from the DEF protocol, are available for free on healthcaretoolbox.org. They're freely downloadable. And I'll show you some more resources on that website as well as we move forward. So again, here are some of the cards. This slide really shows the distress part of this suggested trauma-informed approach. Broken out more. There's cards that providers can carry in their pockets. There's signs that could be hung up in staff rooms. There's handouts for parents as well. But so around this distress, there's specific suggestions included on these cards and in these resources of things that providers can do to help prevent trauma in their families. Some of these include, assessing pain, again, listening carefully. I think we can learn a lot from just sitting back and listening and learning what the family needs. And again, this speaks again to really understanding the family's perception of the event. Clarifying misconceptions. I know sometimes we work with really big teams of people, or sometimes in mental health we're working with school systems, and we're working with sometimes police systems. And so bringing together the people involved and making sure we're giving a consistent message to the child and the family. Paying attention to grief and loss. And in this, it's not just death or the things that we would include as extreme loss or extreme circumstances, but also like, is there something that has happened as a result of this medical hospitalization, or something that's happened as a result of this mental health diagnosis that is going to change something that the child or the family had in mind for their future? For example, an injury where they can't play sports, even just for that season, they might need to grieve the loss of that opportunity. So the emotional support card talks about, encouraging parental presence. In most cases, this is really helpful for kids and parents, empowering our parents to help with their child. So this is not suggesting more resources from the hospital, but really helping the parent mobilize themselves so the parent can be the key supporter as their child recovers from these different events. Encouraging social support in return to normal activities. And for the family, learning about assessing the family, looking at other needs, gauging the family, remembering that the way that parents are recovering from these kinds of events affects the way that kids recover from these events. So keeping these sorts of things in mind. And then I think this card is really, if you think about trauma-informed care, this is certainly culturally sensitive trauma-informed care, but a key aspect of trauma-informed care is really we want to be listening. Ask, listen and see if there's differences in the patient's culture. If you ask questions like what is causing the most distress, or what is causing their distress, or what is worrying them, it gives you an idea about what the primary concerns are for that family. being open and not assuming that a patient or a family should turn to a specific group or specific person. Sometimes some of the chaplains can be very helpful if that fits in with the cultural belief system of that family, or sometimes we need to talk to the mother because that's the only one who is permitted to run the family. Sometimes we need to talk to the father because that's the leader of the family. So really getting a sense of, what are the key people for that family, and just respecting, of course, like respecting who makes the decision, respecting what kind of information that we can share with families. So an example of some research that's been done that actually put this DEF screening into practice, I think really highlights for us the ability for our teams to have an impact on our patient and family recovery. So in screening over 500 patients and families, 45% identified at least one concern that the medical team could then intervene with and then support. So I think it's evidence for suggesting that a lot of things are going on for our families besides just the basic physical care. We need to extend and think about the emotional care and other support as well. So thinking about responding, we want to make sure that we know when we should refer for psychological help and how to manage our own reactions. So basic guidance about referring to get more help. If you have concerns about your safety, your individual level of comfort, and impairment of symptoms. So anytime you have concerns about your safety or the patient's safety, you absolutely need to bring in another consultation person or other support. Sometimes this means calling security to make sure that everyone is safe in the room. Sometimes it means getting a mental health consult, depending on the situation. You also have to, understand what your individual level of comfort is, and if it feels uncomfortable for you, that means you need to get some other assistance. And that could be as simple as asking another colleague for their opinion or their support, or it could be getting a consultation again. And then impairment of symptoms. When we see kids that are having reactions that are impacting the way they can react with their family, impacting the way to that they're able to function in school, impacting how they have their peer relationships. These are things that we definitely don't want to let go, and we don't want to let get bigger for the kids, so at those times it's definitely potential time to refer for more assistance. So thinking about managing our own reactions, there's a couple of key things that we can think about. The first just being awareness. So when we are aware of the potential for our own symptoms, we already recognize and kind of behave differently in response to having symptoms. We want to normalize that these experiences are normal, typical. Like when you are dealing with patients and families in challenging situations, you should have emotional reactions. When you stop having emotional reactions, you stop having the ability to really identify with your patient. So these things are very normal. So just recognizing that and not seeing it as a sign of weakness. I think sometimes in the medical community and the mental health community, for providers, we see it as a sign of weakness if we're having trouble managing our own reactions, when really this is happening to providers on a regular basis. We need to give ourselves permission to take a time out. This means, if we're in a room and we need to step back and take a break, we need to give ourselves permission to take a break, go, talk to somebody, cool down, as long as the situation is safe for the patient and safe for ourselves, or take a time out afterwards, take a quick break and just regroup. Seeking out peer support, running, if you have a situation in which you think, oh, I'm not sure about this, or I'm really having a hard time with this, picking up the phone, getting on your pager, calling a peer, taking a break, debriefing about it with each other to help determine, are there ways to help you feel better in your reactions. And then certainly if things are interfering or becoming a problem in your own life or with your own family or with your job, you certainly want to seek professional support at that time. So we have a few minutes before we're going to jump to questions. So I'm just going to fairly quickly run through these potential resources. And as Suzanne mentioned, these slides are going to be provided to you, so you don't have to, run around trying to write everything down. And it's also going to be, the webinar will be posted online as well, so you can go back through and take a look at all the resources as well. So one of the resources I mentioned above when we were talking about the DEF protocol is healthcaretoolbox.org. And so on this website, there's a number of different handouts and downloadable tips for kids and for parents. So there's a number of things that you can take a look at, and there's things that you can give directly to your parents. These are free of charge. You can also order color copies as well. On this website as well, I want to point out there are some additional webinars, and there is one course currently for nurses that you can get CE credit, free CE credit for completing, and it's the D module, the DEF, and the other modules are in development as well. There's another website here after the injury. This is for parents of children that had injuries, and so this is for direct use by parents. So this is a resource that you could potentially provide for your families or patients. And on this website, there's different stories and video clips. There's a quiz where the parent can go in and rate their child's symptoms and then get specialized tips so that they can try to enact those tips to help their child recover, or they can share that information with their medical providers or mental health providers as well. And this really, after the injury website, really focuses around post-traumatic stress reactions. There's another website developed by some colleagues at the University of Queensland in Australia that's been developed specifically for use with kids. And so on this website, this could be integrated into care, like therapeutic care, or it could also be provided as a resource for kids. It talks about feelings, problem solving, reaching out. It teaches some kind of skills for helping recovery following an accident or injury. There's also some additional training available. If you look at Betsy Grove's materials, and I think if you just Google this, you can find some of the PowerPoints and videos that are available. And they've done some work around figuring out how to manage and identify trauma in pediatric settings, in particular working with preschool kids. So there's some additional training available there for providers that are interested. For mental health teams and community mental health centers, the sanctuary model has come up with all-intensive way to change the entire system of your community mental health center to follow a trauma-informed approach. And so there's some great resources here. There's some different publications you can look at, and you can look at what the sanctuary model is and the model that they follow. And in some, they're really thinking about and looking at a system-wide approach. And so how do you change the way trauma affects the entire community mental health system? For mental health providers, there's also a resource that teaches trauma-informed cognitive behavioral therapy. And this is a free online resource. You can get CE credits on this resource as well. And it teaches about trauma-informed CBT for as applied to kids that have experienced traumatic events, including violence and sexual abuse, and as well as things like medical trauma. So other things that may be of interest from a parent, if you want to read more from a parent's perspective, this parent wrote an excellent blog about the golden cocoon of the medical experience that she had with her family. And one of the things that I think is highlighted so beautifully in this blog is she talks about this experience that she had with the head of a department taking the time out of his busy day to walk the child down to a different room to help the child get their care facilitated. So even though that was not in his job description and there's other people that could potentially handle that, he recognized that there was a problem going on for this family and stepped in and handled it himself. So really showing that when you're thinking about from a system, how members across the entire system can really be helpful and can make a huge difference for families. There's additional materials also available at the National Child Traumatic Stress Network website. And that applies to kids in all different kinds of trauma, and the National Center for PTSD also has some more resources. So for summary from today's talk, things that we would like you to take with you, again, is to really realize the trauma exposure and its impact. So how many kids are exposed to trauma and how it affects our families. Recognizing that the types of reactions and what it looks like to have trauma in families and staff, and keeping this in mind across all the kids that you're working with and for all staff. You know, some of our frontline staff people get the brunt of some of our challenging situations, and we need to make sure that we're putting things into place to support everyone. And then how do we respond? Like, can we put a DEF protocol in place? Like, what are other resources that we can think of to support each other and support our families? And then coming up with more training opportunities. At CHOP, we're working with various departments to tailor training so that we can make sure that across the hospital. We are implementing trauma-informed care across all of our situations. There's a few resources available here as well, which again will be posted. And we just want to do a quick thank you to the number of funders that have funded this kind of work over the years. And that brings us to our question part of the webinar. So we have a few minutes left that we're going to be reviewing some questions.
Thank you, Dr. Marsac. That was so wonderful. And I think the resources there really give people things they can do as homework and follow-up and exploration and take a deeper dive into trauma-informed care. So thank you so much. We have about 10 minutes for Dr. Marsac to respond to questions. And I know many of you might have missed the introductory comments where we provided some tips on how to provide questions. If you look at the quote bubble, we have a chat function that looks like a quote bubble in which you can click on and type in questions to our moderator. And then you just click on down below, rather than sending it to all, send it to moderator, and we'll receive those here. We have received a few questions here, and there's some common themes, very practical. One of them is a little bit more general and global. Somebody asked if how common using trauma-informed care are in healthcare systems today. Is it widely used, or is this sort of a new concept that we're working with?
I think that's a great question. So I think we're actually right on the edge of providers and hospitals recognizing the need for a trauma-informed approach. I think a number of hospitals, CHOP included, have recently shifted to family-centered care, which is one step. And I think applying trauma-informed care takes us a step further and really can increase the level of care that we provide for our families. But I think we're right on the cusp of starting that.
Terrific.
Yeah.
Thank you. Another question, here's some kind of practical questions. You spoke a lot about how healthcare providers should recognize symptoms within themselves, and a question came in and said, is it ever appropriate to bring this up to a coworker you feel may be suffering from this? And if so, how might you start that conversation with your coworker?
I think that's a really great question, and I think one of the keys in being able to figure out kind of how to approach that is working on making sure that the culture of our teams is one that we're supporting each other. And when you develop those relationships where you're supporting each other, you have the expectation then that if a coworker notices a problem, they're going to ask you if you're doing okay and what's been going on. So I think in a similar way that you would bring up, oh, I noticed when you came into work and there might, if they were upset about something, we also would ask after a patient situation, we might want to bring up and say, listen, that was really hard for a number of our team members, or I noticed, that was challenging for me. How are you doing with that? Or, is there anything I can do, or do you want to chat about that? So just thinking about ways, of course, very respectfully to ask, but again, I think really the key is to understand that these are normal things for health providers to struggle with. And so given that these are normal experiences, if we accept that, it makes it easier to have these kinds of conversations.
Yeah, perhaps it's something that, the head of a department or the head of a team can kind of say right up front, regularly and often, please feel free to share, please feel free to talk about this. This is common, this is normal, don't be ashamed. Yeah. Another question is, again, quite practical. How do we apply things like DEF in the space of a clinical visit? How do you fit that into a tight time, like a PC well visit or something like that?
I think that's a great question. And I think the idea behind DEF is that you should be able to fit it into those very tight visits. I mean, you could do it in a number of different ways. When the research study was occurred, they had nurses going through a checklist. And so the nurse would run through a really quick question and identify, were there particular problems for that family. So if you have a checklist that you can just go through really quick, and then if you identified something, you could follow up with questions along that. The other thing I think with DEF is as you're talking and doing your normal exam of patients, is if you have DEF in your mind, you're paying attention for those kinds of things that might be coming up even without asking them. And so then if you pick up something within your clinical visit, then it's just another quick question to follow up on it. So it's just partially just shifting our mindset, and it's one more thing to think about in our very, very busy visits, but something to shift our mindset a little bit that can really make a difference for families.
Yeah, great. Someone brought up that, insurance payments can be a huge barrier to this type of follow-up conversation. Are there free referral services for patients that are free that physicians and clinicians can tap into?
So I think that would really depend on the setting that you're practicing in and your location and what's going on. But I think if you have a social worker that you can consult with on site, or if you're in the CHOP network, if you can reach out to a social work department, or you can reach out to the Center for Pediatric Traumatic Stress, they might be able to identify some resources that would be applicable for your patients and families. It's a huge challenge. That's definitely a huge challenge that we have.
Yeah, we had these are sort of practical questions, and I'm sure there's most of these questions can be answered. Yes, go to our websites. Is there a handout for parents on PTSD for themselves? On one of the resources that you listed, she's thinking of NICU parents in particular.
That's a great question. So I believe that I think that there might be on the Healthcare Toolbox website, and if not, if you look at the what they're providing for kids, a lot of it applies to parents. So it could be something that could either easily be adapted or something that there might be resources direct on parent self-care as well. But that'd be something we can talk more about at another time as well.
And do you recommend any brief assessments that can be completed in the primary care settings?
So I think that's kind of a tricky question, because it depends on if you're trying to assess for post-traumatic stress specifically, or if you're doing another mental health assessment, like an overall mental health assessment, versus if you're trying to integrate trauma-informed care into your setting. So if you're really thinking trauma-informed care and basic assessment, you could use a checklist that cover, and I believe that this is available on the Healthcare Toolbox website. There's a DEF checklist that you could use, that you could complete within the primary care assessment. If you want more of a questionnaire, there's some that are tailored for post-traumatic stress, like there's a child PTSD checklist that is very useful as well. So I think you really have to think about exactly what you're trying to assess.
Okay, so here's, while we still have a few times, I'm just running through some things that aren't necessarily fit into themes, but are there simple ways to decrease distress using physical space, waiting room, or exam rooms? And do you have any simple ways to decrease distress with giving shots? I've seen nurses having to, hold on, let me grab my arrow here, having to hold down kids for shots, which causes more distress.
Yeah, I think those are really great questions, and in answer, there's absolutely ways to set up the physical space. And in the one case case example that I gave, where the child, that was exactly what was happening. They were having to be held down for shots or blood draws. And one of the things that we did is we moved, in that case, rather than doing them in the general phlebotomy lab where there's a lot of kids and a lot more commotion, we moved them into a quiet space. We had a consistent nurse deliver each shot for that child, because that was a challenging situation. Also, some places have child life specialists that can come in and help prepare the child for procedures, including shots, or distract during the shots. We know there's some great websites about immunization now too that give simple tips about how to do those kind of regular application of shots and vaccines, but distraction for shots often helps. As far as the physical waiting space, I think things that are good are waiting rooms that have enough space. I know my personal experience with my own child was, when we were in a waiting room where it's really crowded and you have something very stressful going on with your family, that's a lot more stressful for families. So ensuring that there is actual space, and then setting them up in a child-friendly way, setting them up so there's things for kids to do while they're in the waiting room, so they're not focused on the medical care, or while they're in the exam rooms, and even just using kid colors, making it more friendly. There's a lot of things that can be done to physical space to make it more comfortable, making it a more child-friendly environment.
I know there's interior designers that help design our new South Tower at CHOP that
Mhm.
did exactly that.
Mhm.
You know, they know how to incorporate that into just the interior design, which is remarkable. Well, thank you. We're in the final minutes of our 1 hour webinar, and so we'll take this time to conclude the webinar. As I mentioned in the introductory comments, you're going to be receiving an email with the link to the video once it's posted, and we'll be sending, if you had signed up for this and provided your email address, you'll also get a PDF of the handouts of the PowerPoint slides. And we hope that within that you'll see a link to join our e-blast list so you can hear about our future violence prevention related webinars from CHOP, as well as receive relevant research news. And so we hope you'll join our community. Thank you so much to Dr. Marsac and for all of you who joined us here today and participated in providing questions. This concludes the webinar, and we hope to hear from you all soon. Thank you. Bye-bye.